going to begin recording. So the purpose of this webinar is to serve as a sort of office hours to hear questions and help you troubleshoot as you're setting up and running medical legal partnerships. So this will be interactive. If you would like to speak or offer a point, please go ahead and message NLADA WebEx administrator, and we can go ahead and give you speaker privileges. All right, so today's presenters, hello everyone, my name is Casey Chiapetta. I am with the Civil Legal Services team here at NLADA. Also joining us from NLADA is Radhika Singh, and we also have Ellen Lawton, the co-director of the National Center for Medical Legal Partnership. This is a center within George Washington University, and Ellen will be the one who will be mainly answering your questions. NLADA will chime in here and there. So the agenda for this webinar today, we're going to go over a little bit on how to participate. In the past, we've had some technical difficulties with WebEx, as I'm sure some of you have experienced. So we're going to make sure that we preemptively avoid any issues. We also sent out a survey for those who have registered for this webinar, and I've compiled a list of the topics people are interested in. Then we will hear from the National Center and Ellen, and the most part we will have interactive office hours. Great. So if you can hear us, congratulations, you have completed the first step. When we will be calling on you and having you speak, or if you would like to speak, we will give you speaker privileges. You don't have to do anything on your side except when a little pop-up comes up on the lower right-hand side, you press connect, and you are good to go. When you want to participate and we haven't called on you, go ahead and send NLADA WebEx administrator a message. You can do that by either clicking on our name on the right-hand side or in the little chat bubble circle at the bottom of your page. And if at any point you have difficulties, send us a message and we will help you troubleshoot those. All right, so these topics come from a survey that people took before we had the webinar. So this webinar really comes out of expressed interest on one of the MIE listservs, the fundraisers listserv. There were some questions about how do we set up MLPs in health centers. So we invited Ellen Lawton to come and speak on this webinar and answer your questions. So these topics come from the survey that people took when we were coming up with what we wanted to share today. So most of the people in here are currently in an MLP, and about a quarter of them are in an MLP that began within the last year. An eighth are actively pursuing one, and another eighth are interested in learning more to see if they want to pursue it. So we have a range of experiences, and we're hoping that this webinar can speak to the majority of them. So as we're going through, start thinking about questions because there will be an extended time at the end for you to ask them. So with that, I'm going to go ahead and turn it on over to Ellen from the National Center, and she will start talking about medical legal partnerships and the resources they have to offer. So Ellen, do you want to unmute?
Hi, friends. Can you hear me?
Yes, thank you.
Yay! Okay. Hi, everybody. This is Ellen Lawton. I'm at the National Center for Medical Legal Partnership. I'm so excited to have this time to chat with you today about medical legal partnership in the health center context. And certainly shout out to Radhika for her leadership in cementing medical legal partnership practice as part of how NLADA thinks about their work and their convening. So thanks, Radhika, for that. And also Casey for putting this together and being so thoughtful about data collection with you all, because you filled out those surveys and it was super helpful to me as I put this together to see the breadth of experience that's out there listening and hopefully participating and weighing in, and really to think about what are the things that are challenging and where you all need help, not just from me or the National Center website, but from each other. So to the extent possible, and if the technology permits, I'm hoping that we can get a little lively here if I'm able to view the attendee list, because I really, having reviewed the attendee list and having seen who's participating and folks who responded to the survey, you have so much experience. There's at least a dozen of you out there who could be sitting in my chair doing this presentation right now because you've been thinking about doing medical legal partnership for a long time. And so I really want all of you to have the benefit of each other's experience, each other's mistakes, we all make them, and then each other's thoughtful contributions to how to sustain this work and how to deepen it and grow it and do it more effectively. So now I have to go to the next slide. How do I do that? Casey, there's something that I pushed.
If you move your mouse around the screen, a long oval should pop up on the left-hand side, and you should see a 06. If you press the button underneath it, it'll take you to the next page, the little down arrow.
A down arrow? Wait, it just made it grow. Oops. Oh, I see. Sorry, folks. The first problem when you give me, the presenter, guidance here.
If you want, I can.
Why don't you just do next slide? That I can roll with that. My tech skills are going to keep up with my mouse. And I want to say, too, again, there are so many of you who thoughtfully submitted your data, and it's super important and very helpful just in general to folks at the National Center as we try to make sure we're connected with you all is to pop questions or comments in the chat box. Because we have 35 folks on the call, and so you might not be able to weigh in, and you might be, in transit or something. I'm not in front of a computer, but certainly happy to hear from you in the chat box. So what I'm going to do right now is actually I'm going to run through kind of a basic slide deck that we use, and again, with apologies to some long-term practitioners out there who have maybe heard this a dozen times already. I hope not. Hopefully there's some new stuff in there. But maybe you'll hear something different, or maybe it'll inspire you to share what has been helpful to you as you've developed your medical legal partnership in your community. And so I'm going to run through this deck so that we just all have a basic foundation here. And then I'm going to invite people, and hopefully we can figure out a coordinated way to do this, is to, I can pluck people off of the list for sure, law school style, but call on folks, because it would be great to hear from some of you in terms of what you're doing in your communities. There's a lot of MLP experience out there, and I'd like to bring it into the center of the room. So with that, Casey, can we go to the next slide? Are we there?
Did it not go?
I don't see it. Oh, there we go. Okay. Great. So this is our basic definition for medical legal partnership, right? It's not too wonky, and this is how we describe it. Just shrink that down a little so I can see the title. Is medical legal partnerships integrate legal services as part of the healthcare team, resolving patient problems, consulting with clinical and non-clinical staff, and leveraging expertise to advance local and state policies. That's a working definition. We've got lots of them. Next slide. This is probably familiar to many of you. You might want to shrink that slide up a little, Casey. I can't see it on my screen. It kind of it's a little large, but this is a chart that talks about where lawyers fit in resolving SDOH problems. And so if you're on this call and you don't know what SDOH means, I'd love to hear from you in the chat box, because that's a very common term, getting more common all the time, social determinants of health, and we are squarely in that sector as legal aid lawyers. And you can see on the left, these are the domains where the practices are sort of delineated in this chart that we at the National Center built. And then you can see on the right-hand side, you know, what lawyers do. This is what you all do, and you know well. But you can see the descriptions, right, are tight and short, so that we can explain to others what we do to resolve SDOH problems. Next slide. This is an example, we're going to come back to this. An example of the National Center is that we have strategic partnerships with federal agencies, different federal agencies. We're going to spend most of our time on the top one, HRSA, the Health Resources and Services Administration, which is part of Department of Health and Human Services. CMS also is aware of medical legal partnership issues and activities, and has recognized screening for health harming legal needs as a specific type of activity within its rubric. Go below that to SAMHSA. Medical legal partnership was singled out in language in a recent blocks grant release of funds, and so that has created some opportunities. And again, I'm having a hard time seeing the screen, so I can't see all the way to the bottom.
Can you try zooming out on your screen, Ellen? If you move your mouse over the general screen on the left-hand side, there we
go. Thank you.
Yep, great.
Okay. I thought you were controlling that. I didn't realize I was. Okay, thanks. And then some of you on the call I know are working with veterans, and you're working in VA settings. And, you know, hopefully, and Radhika can even speak to this a little bit, we're hoping that, you know, the VA will follow the lead of HRSA, which is to recognize legal services as part of how they do business. And they'll go way beyond encouraging medical centers to provide free space for on-site legal care, which is really, it's important and essential, but really we need resources in order to pay for the services that lawyers are providing in the healthcare setting. Next slide. And so some basic resources that I really want to draw your attention to. It's kind of easy to skip over them, I think, at times, because they may seem a little dated. The most recent survey of the National Center of the Medical Legal Partnership field is from 2016. I would just say that the content and the findings are still super relevant to the work that you're doing right now. And so you can find in the data that we put together a lot of trends and themes and language about what's happening in the field, where MLP is active, where it might be struggling, examples of, you know, a sample budget, sample activities that medical legal partnerships pursue. So it's a really terrific core document that I think might not get enough play in terms of, especially those of you on the call who are trying to just get started building up your MLP. I want to say right now, too, that we are actually sunsetting a toolkit that we've had on the website. We've had for about almost 5 years. It's from 2015. We're sunsetting that toolkit. Some of you out there might have contributed to it. You might be using it. We think we've got a lot fresher content and a lot more of the stories and tools from the field that we think are going to really help you to accelerate and deepen your partnerships. So if you've got that as a, you know, guide sitting on your desk, just know that we're actually going to release sometime in 2020 a new health center focused toolkit. We're calling it a readiness guide that I think is going to try to house a lot of these new stories and tools and trends and practices under one umbrella with focus on health centers. And it will mimic in many ways the readiness guide that we generated for veterans that was released in May. So I would say, in the meantime, even if you're not working with veterans, there is a significant amount of content that is foundational and persists across populations and settings. So even if you're not working with veterans, I would highly recommend that you look at the Veteran Readiness Guide, because you're going to see some themes and practices and suggestions in there that will resonate for you no matter what setting you're practicing. Okay, next slide. So this is I think, a really important foundational article for the medical legal partnership field, because it really lays out, it came out in March of 2018, and it's really informed how we built our VA readiness guide. It's going to inform how we build our health center readiness guide. And it lays out these components of MLP, which for those of you out there who have been practicing for a long time, it feels very obvious, right? Lawyer in residence. Of course, that's kind of the paradigmatic core component. But informal agreements between the health and legal organizations, right? But you come down to target population, right? That becomes increasingly important for medical legal partnerships. And I strongly suggest that you take a peek at this article. It's only, 4 or 5 pages long, but it talks about why it's important to target a population, how that has an effect on your ability to measure the impact of your work, your ability to secure funding, and other ramifications, right? Coming down to screening patients for legal needs, there's been a huge movement around screening broadly for social determinants, and we've, as a movement, and many of you out there have thought a lot about how to do that screening, how to do it efficiently, and who should be doing that screening. So we've got resources on that, and we're going to get to some new resources that are really exciting from the AAMC. So, and then some other components that are obvious but require some thought, right, which is what kind of legal staffing do you have, for example, or do you have a paralegal who's perhaps stationed at the health center? What kind of training on social determinants is happening? Is it only, should we only be training the healthcare providers, or actually maybe the healthcare providers should be training the legal team, and what should they be training us on? Next slide. In terms of strictly focused on health center medical legal partnerships, right? And so when we talk about health centers, what are we talking about? We're talking about what I would say the equivalent of Legal Services Corporation funded health care organizations, right? So this is the spine nationally of primary care health services for low-income populations, right? So there's a federal agency, that's HRSA, and they provide funding for a network of 1,400 what are called federally qualified community health centers, right? And so FQHC is the term that is often used to describe these health centers, and they can be as small as, they see 400 or 500 patients a year, and they can be as large as seeing, hundreds of thousands of patients a year. And so in many ways, they are similar to LSC programs in that they're federally funded, they're very highly regulated, they basically cover all of the geographic area of the U.S., and so you can always find a federally qualified health center within a certain geographic area. And so they make very smart partners for LSC-funded programs and other legal aid programs. And so we can talk more about that. So as part of HRSA and our strategic partnership with HRSA, the National Center has a training and technical assistance grant that helps us to reach directly to health centers and talk to them about the value of incorporating legal services as part of how they do business in their health centers. And so that has given us the opportunity to help many of you on the call to bridge with health centers and their statewide coordinating agencies, which are called primary care associations, in order to try to figure out how can I deliver legal services in a way that makes sense for health centers, in a way that boosts their capacity, and makes sense for us financially and from a mission standpoint. Okay, so we produced this issue brief, which was a snapshot of MLP activity in the health centers, and that came out in winter of 2018. And so this is a great tool, first of all, for you to review and kind of capture, the status of MLP and the language that we use, and also to gain a better understanding of the health center field, how they think, how they are funded, how they think about their work, and what their priorities are. Next slide. And this is just a little snapshot from the issue brief that focuses on, health centers that have MLPs, what do they look like? And, what are their particular attributes in terms of staff, in terms of budget, and in terms of populations that they serve. So I would estimate now that there are medical legal partnerships in about probably closer to 15% of federally qualified health centers. So we're looking at about close to 200, somewhere between 150 and 200 health centers that have MLP programs or are in the midst of growing an MLP program. And we can talk about what that looks like. Next slide. Okay, so the key takeaways, this is referencing actually a MLP financing issue brief that Casey had provided and is available on our website and on NLADA's website. And it just talks about sources of stability of funding. And this is from a recent webinar that we presented back in May. That was the result of a review and some intensive data collection with about 15 healthcare partners, MLP partners, looking at average budget, looking at staffing, looking at where their funding comes from. And so that webinar, again, which is on our website and accompanies our finance issue brief, really drills down into the specifics of how you build an MLP, but also where's the funding coming from for different programs around the country. And it is quite variable, and the operating budgets are quite variable from, enormous programs like in New York with legal health that has a pretty significant budget down to much smaller programs where you may have just, a half-time or a full-time legal aid attorney in a rural health center or two. So the variation is significant and important to account for, and then the types of funding that are then getting plugged in to support that time is also important to note. Next slide. I want to call your attention to this study, and this is highlighted in an issue brief that we did on veterans, and this is highlighted in an excellent study and a report on a study that was in Health Affairs that focused on veterans, but it has some themes there that I think are really important for the MLP movement in general, where it talks about the cost of medical legal partnerships that are focused on homeless veterans. And they gave estimates in terms of the amount of time needed to resolve legal issues. They were averaging the average amount of cost to resolve legal issues, and then they were able to tease out, the cost per legal issue addressed. And this has been pretty important information going to what I know some of you have asked for, which is how do I calculate our time and our impact so that I can build a contract with a healthcare partner, right? So these are some data points that you can point to give estimates as you're trying to think about contracting. So that's number one. Number two, going back to the previous slide where the Manat Health financing webinar that we offered back in May, talk specifically about contracting and contracting language and how to think about and work with healthcare partners in order to build a language of contracting that doesn't look like your typical kind of, quote, legal aid engagement or contract. Next slide. I'm sharing here a couple of slides from our friends at Whitman Walker Health. And so for those of you who aren't familiar with Whitman Walker, they have a significant, they're a federally qualified health center in Washington, based in Washington, D.C. They have a significant legal team that is part and parcel of the health center. And I wanted to give you a sense of, and to share with you how they talk about the work that they do. Because it's significant, because it's also in some of the language that health centers use and also in the language that some legal aid providers use. So, next slide. And then this is another slide from Whitman Walker Health where they are talking about their legal cases, the total number of patients that they're seeing, right, what the numbers are in terms of legal cases, or legal-only cases, what are some of the topics in the breakdown of their legal services. Again, just to give you a sense of a very, very well-integrated program, how they think about their legal services, how they tag them and bucket them, and what are some of the activities that they pursue. Next slide. Okay, we're coming up on the end here, and so I want people to get ready to get called on and to share with us. And maybe even somebody could ping in the chat box. If you've been doing an MLP project and working on MLP for more than, say, 2 years, ping us in the chat box and tell us that you're willing to raise your hand and chat about what it is that you do. So I'll be looking for that feedback while I move through these next couple of slides. So, back it up. There we go. Healthcare equivalents of legal services. For those of you who have been doing MLP work out there, you know that it's important to try to frame your work in the context of your healthcare partners, which means you've got to learn the language that they speak. Going back to my opening kind of analogy there, I talked about federal legal aid being very similar to federally qualified health centers, right? And there's an animal called a lookalike community health center that doesn't have federal funding, but it could apply for federal funding. And those are kind of analogous to the many state and local legal aid organizations that may be on this call today and that are contributing to and supporting and working in tandem with LSC-funded programs. Moving along the top of the chart there, private pro bono resources or bar associations have an analogous kind of counterpart on the healthcare side, which is a free clinic, right? So they're provided important capacity, but they aren't as dependable, they aren't as structured, and they aren't as expensive or as I think woven into practice as LSC programs and state and local legal aid. And again, just trying to give you a sense of the funding, and I stand corrected by Radhika if she wants to come in and say, actually, ooh, that's all wrong, Ellen. So, this is our best guess when we built this slide. Next slide. Great. So I just want to talk a little bit about this amazing health center CEO, if there's anybody here from Indiana. Indiana Legal Services is a long been a hotbed of medical legal partnership, and Beth Robel leads a health center in northern Indiana that reaches hundreds of thousands of patients a year. It's one of these enormous health centers with multiple offices. And most recently, she had an opportunity to apply for some significant substance use disorder funding for her health center. And she, as part of that, included funds for a legal aid attorney because she didn't need to be convinced that the legal aid attorney was going to help her to achieve her goals under this SUD funding activity, right, which was to reach more patients with substance use disorder and stabilize them and ensure that they were successful in their recovery. And she knew she needed a legal aid attorney to do that. And when I asked her to please articulate for the field what is it that she said in this grant, she said, candidly, it wasn't much. She didn't have to do a huge justification. She just had to talk a little bit about how the legal aid attorney would contribute to the goals and objectives of this grant. And I say that to you because there's no magic bullet for some of these descriptors. It's really the fact that Beth Robel understands well what legal aid does. She's seen them in action, and she knew that the service had value and that it was going to help her to achieve her goals for this new grant, which takes time and takes relationship building. So next slide. I'm not seeing anyone having entered a chat message here. Casey, are you?
No, I'm not either. Attendees, if you have any questions, please send them on over. We want this to be as interactive as possible.
Okay, because you don't want me to call on you, folks. Okay. So this is, I'm going to talk about MLP as an enabling service. So, and part of going back to what Casey had said earlier about the impetus for this webinar in particular was that I believe it went out somewhere on maybe an MIE listserv, inviting applicants for a service area competition that was exclusively targeted to health centers, right? And the idea was that, if you have legal services, this might be a funding mechanism for you because MLP had been designated as an enabling service for HRSA, right? So there was some confusion about what that meant and confusion about how to take advantage of this policy change. That's actually a really important one and I think a really valuable pathway for legal aid. And so just to give you the background, in 2014, and again, the result of lots of really hard work in the field by some of you out there who helped to convince people like Beth Robel that it was important to include lawyers as part of the suite of services called enabling services that enable people to participate in primary care. And so those enabling services include transportation services, case management, interpreter services, outreach services, and now legal services, right? So by inserting that piece of language in there, it meant that health centers, which have a certain amount of their budget, their federal budget, that can be allocated towards enabling services broadly, can include some funding for legal services, okay? So it's the big budget for the health center. There's a smaller portion that's called enabling services, and that piece of that can be used to support civil legal services for health center patients. And it's up to the health center to figure out what that means. And so what that means is that you have to build your relationship with your health center leaders and your health center practitioners and think with them about how does it make sense for them to include you in the enabling services budgeting process. Is that something that you can do on your own and apply to HRSA for funds? No. The analogy would be, it would be like a health center going to the Legal Services Corporation and saying, hey, I want to hire a couple of attorneys. Can you give me some money to do that, right? The way that you the way that you get access to health center resources that came about through this enabling service change is by talking with health centers that are applying for 330 grants and helping them understand where you fit in that suite of services those enabling services so that you can get funded some level of legal services specific to that particular health center. So you have to thread the needle, and you have to really work with your partners to figure out where it makes sense for you to deploy your services. So you can see enabling services, that last bullet, are not clinical in nature, but they help facilitate access to care and improve patients' health, right? So I think that's a really critical notion, right? Because imagine, again, reversing the order. If a health center came to you and said, hey, I heard that there were these access to justice funds. Can you apply for those funds and give us a paralegal, right? You might be like, hey, we've got different priorities, actually, and we have other partners and things that we're interested in. And you might feel, if there weren't a relationship there, that they were actually kind of just using you to get to your funding sources, right? So there's a little bit of that happens in the health center world. But there's also a significant interest in the health center world to partner with community partners exactly like legal services, and they're looking for those opportunities. And they aren't always sure where you fit, what your work needs to look like, and how you can best maximize this opportunity. And that's where that's the space that the National Center tries to come in and really help health centers better understand legal aid and how legal aid works, and then vice versa, hopefully supporting you all to better understand how health centers operate, how they think, and what they need, and where you can kind of meet them where they are. Next slide. Oh, we're at the Q&A. There you have it. Okay. So, what I'd love to do, I haven't seen anyone in the chat, but I know that we have friends from Florida, Rural Legal Assistance, I believe, that just got a new grant, and they're looking at medical legal partnerships in 2 community health centers, if I'm not mistaken. And so we'd love to hear from you all, because if you could share some burning questions with us, there might be folks on the call who can respond, and there might be, I'm happy to weigh in, as is Radhika. So can you help us?
Yep,
Casey?
so I just added Daniel Cruz from Florida to the panel, so hopefully Daniel can go ahead and connect the audio. You should have gotten a little pop-up saying connect. Let us know if you didn't. Is there anyone else that you want us to make sure we highlight, Ellen? And I can go ahead and make them panelists now, so we don't have to keep going through this.
So I'm going to call in, of course I have to call in Janice Cower, because Janice, you were just at if you're on the line, you were just at our summit, and I know you've got a lot going on in New Mexico, and we'd love to hear, if you have some burning questions that we can tackle here.
I don't see Janice.
Okay. And then Karen Miller, I know you're new in your role, but you guys, you're featured in Keegan Warren Clem's work is so great, and you're featured in the case study that we did with People's Community Clinics. So if you wanted to step in the circle and share a question or a comment, we'd love to see it. So. And
then Amy Burns, also from is also here and wants to speak. So I have Amy, Daniel, Janice, and Karen. I've made you all panelists. But it doesn't look like you have connected your audio. So if you go up to the top of the screen where it says File, Edit, Share, View, click on Communicate, and then press Audio Connection, and then it should allow you to connect your audio so you can go ahead and speak.
So while you guys are trying to do that, and the minute that you feel like you can say hi, please do, and I'll stop talking. It sounds like somebody came in there. Whoa. Yep, mute them up. Thank you. Sorry, that's what happens when you might be on your computer, and is that right, Casey?
Not sure 100% of the time why it happens, but I do see that we have Janice, and it doesn't look like Janice is muted. So Janice, can you try saying something for us?
Yes, how's that working?
That's great.
Fabulous.
Okay. Thanks, I'm kind of technologically challenged here.
You're doing great.
Thank you.
Janice, thank you for stepping in the circle. And, I think it'd be great if you could offer some comments and thoughts and, ask questions, wherever you want to start, Janice.
Okay.
You want to start tell people a little bit about what you're doing and where you're going.
Okay. We started on a medical legal partnership project in 2017. It's a larger project that now involves multiple states and apparently hundreds of tribes, called Partnering for Native Health. And in the first 3-year cycle of an AmeriCorps grant, we were the lead grantee because of our just ability to administer the grant. But in our own small programmatic part, we had one AmeriCorps attorney at the Urban Indian Clinic here in Albuquerque. That is still an ongoing project, and the lead grantee in a second cycle is now Alaska. So on that basis of that, what we've considered a pilot project, we've got very interested in medical legal partnerships as a strategic direction for our organization, and have been working since that time to try to really spread the word and see what more we could do. So I'm very happy that we're just signing a contract with a hospital in Santa Fe that will establish what hopefully will be an ongoing project funded essentially by the hospital. And we've got a number of other irons in the fire. So I did have one question, and it had to do with your comment, Ellen, about the enabling services segment of a federally qualified health clinic's operating budget. Is there typically an amount that must be dedicated to enabling services, or could it be, as little as zero? So it's up to the organization itself to determine if there's anything in that segment.
You know what? I don't know the answer. That's a great question. And yes, it is. It's a portion of the budget, I believe, right? It might be 10%, something like that. So it is, an allocation in terms of budget. But I think those are such great questions to bring to your healthcare partners, right? You don't necessarily want to lead with them,
right? But
it's good to know, right? And, the analogy I always use is, imagine if a health center came to, an LSC-funded program and said, hey, can you guys include some community health workers as part of the LSC grant that you get, right? And you would be like, no, we don't get enough money to do that. But, if you sat and talked about your goals and the things that you want to achieve together, there actually might be a way in which you could conceive of that kind of joint funding, right? And so it's important to sit with your partners and think with them about what they're trying to achieve and where you fit, and do some experimenting and starting small, going back to our core components article where it talks about target population. I think we have challenges when we try to be all things to all people, right? And so to the extent that you can target or be open to targeting, right, Janice? So like if the health center is targeting, transportation issues for a certain population, figuring out where you might fit in that priority.
And actually, that's a great point, Ellen, because that's exactly what the hospital did. We helped them think through what their priorities were, and they were really already in their thinking way down the line. They have 3 or 4, really difficult populations that they're trying to figure out how to optimally serve. And as they got this one woman that I was working with started to understand what we could offer them, she just saw how things dovetailed.
Right. Great. Thank you for that. I see we have a question in the chat box, but Janice, if you had here's what if I were out in the audience, I'd want to know is how big is that grant you're getting from the hospital, and what are they paying you to do?
It is in the vicinity of $100,000, which commits one attorney in a full-time way to their hospital.
Got it. And do you have a commitment in terms of the topical area, or that's what you were?
That's part of
conversations you're having.
Yeah, it's part of the memorandum of understanding that we're working on. There's both a contract and an MOU. The contract is with they're a little bit more complex structurally than might be typical, but the contract is with the funding corporate entity, and the MOU is really with the hospital, so it's dealing more with the service end of things.
Got it. Okay. Anybody have questions for Janice? Maybe you want to mute up, Janice, and then we can come back to you if folks have questions. Thank you so much for sharing. I really appreciate that. Yeah. There's a question in the chat box I'm going to read out from Lisa Dos Santos. So I'll just read it out in case folks aren't necessarily in front of a screen. But it says, we at Florida Rural Legal Services are in the process of setting up an MLP program with Florida Community Health Centers. One of our biggest questions is how to track healthcare outcomes. How detailed does the expected health benefit need to be post-legal assistance? Must it be tied to the ICD-10 diagnosis? How long should the health center track the patient's health record to determine whether there is sufficient data to track health outcomes statistically? Great. Thank you so much for this question, Lisa. So I'm going to take a stab at it, but I really, again, want to invite anyone on this call. I think we had somebody from a health center, actually, who signed up and at least filled out a survey, whether or not he's here in the audience, George Papadimitriou from West Palm Beach. And so I'm going to take a stab at that, but I think it would be great for us to sort of huddle around this question, because we get this kind of question a lot, right? I'm setting up an MLP program, and I want to track healthcare outcomes. So number one, we are legal aid organizations, and we need our partners to do the tracking on healthcare outcomes, right? Because that's their job, and that's we're not equipped to track that. Although there's been some great work, certainly those of you who are familiar with Mallory Curran and the great work that she's been doing for some time now, and particularly in Florida, and I think Rural Legal Services, you guys have been part of some of the work that's happened in terms of that Florida statewide collaboration to try to make an approximate guess about what a health outcome might look like for a housing intervention, for example, right? We can talk about that, but you are not conducting a research study, right? And so just thinking about what is the purpose of that data collection, right, for this expected health benefit, that is a question for your health partners, right, is what do you need to invest in us? That's kind of how I would approach that question with your healthcare partners is, if you can imagine a scenario, right, in the next 2 years where you would say to your partners, we now want you, Health Center, to invest in supporting this legal team that, came in maybe through a grant from a foundation, but now we want you to take on the responsibility of paying for this service, or else we're not going to be able to provide the service anymore, right? And when you frame it like that, then they have to think in their own rubric and under their own program dynamics, well, what is it that we really want the legal team to do so that they demonstrate value for our patients such that we would include them in our budget in 2 years, right? And that's a little bit about what has happened at the Austin People's Community Clinic, so you can read that case study, where the legal team demonstrated sufficient value, not just around patient interventions, but also around boosting capacity for their entire workforce to do a better job on screening, to do a better job at identifying legal issues and working on some clear policy issues for particular domains, right? So it means that you shouldn't be in the business of telling a health center how long to track a patient's health record to determine, I'm just reading back the question, to determine whether there's sufficient data to track health outcomes statistically. They are the health partners, right? And so the question is, where do you want to shine their flashlight, health center, in terms of your patient well-being, right? Because however much funding you get, it's probably not sufficient to provide comprehensive legal services for every single patient at the health center. I'm asking Lisa, you can reply on the chat if you can't weigh in on the verbally. And so you will, I think that's a good question for your healthcare partners, where we have this limited budget and a limited staffing. Where are we going to have the best and most important impact for you, Health Center, so that in 2 years, if you can say, for example, we have affected all of the asthmatics in our patient panel positively, improved their housing for all asthmatics that are seen in our clinic. Would that then merit an investment from the health center's operating budget, right? I think that is the question that you want to ask them straight up, because you can collect lots of different types of health data, but it might not add up to anything that makes sense for the health center beyond, some patients got really important benefits, right? So I would ask the health center for their help to build where it is that you should be doing that work, and working together to think about how you can deploy this scarce legal service. One of the analogies that a lot of the health centers I think really find very helpful is in team-based care. For example, in behavioral health, you may have 4 or 5 different team members around the table: a behavioral health clinician, a nurse practitioner, and a case manager, et cetera. And you may have a psychiatrist, right? And that psychiatrist is a pretty scarce and valuable resource. So they deploy it very specifically and judiciously, and they don't just send any patient to see the psychiatrist. There's pretty heavy screening and triage. So when you talk to a health center and say, think of me as the social determinants psychiatrist, right, that there isn't that much resource available, where's the place that I'm going to do the most good with the resources that we have? Great. I see we have questions from the field. Go. I'll stop talking.
Great. So we have one from Megan Scully. And Megan says, to add to what Ellen is saying, I would add to be careful that you don't go overboard with data collection on the legal side. Make sure that if you are tracking extra data in the case management system, that there is a purpose, and the purpose is connected to what the health partner needs in order to show the value of having a lawyer on the care team. So don't just collect data to collect data. Make sure that it has a purpose. And then we also have another one. This is from Alicia Strange. We have just received a grant from Empire Health Foundation. It will employ 2 full-time attorneys, 1 full legal assistant, and 1 screener/intake. I will be the legal assistant for the grant. I'm new to the MLP side. Does anyone have tips or suggestions for starting out on this new adventure? So I will open that up to the panelists and Ellen, but if any of the attendees also have thoughts on any tips or suggestions, please go ahead and message us, and we will share that with the crowd.
Great. Do we have anybody on who are open and available to talk that want to share? I'm happy to channel some of the learnings until somebody is able to unmute. Yeah, go ahead.
Can you hear me?
Yeah.
Oh, wow. Okay. This is Amy. I know that Daniel and Lisa are on, but I think they're not able to talk for some reason because they're actually heading up the MLPs. We have the one that's at the VA health center and another one that's with the Florida Community Health Centers. But I guess what I was going to say in response to that, and Lisa probably would be able to say the same thing, is I think the most important thing is communication. I think the more that you communicate with the healthcare provider, the better things seem to be going. I think that because we're coming into their space and we want to be able to sort of get in there and work, but not interfere with what they're already doing so well. So I think that if that was the question, like what tips would you have for getting one started, is just to do what you've already said and just sort of work with them and talk to them as much as possible so you can see how you can add to what they're doing. And that was just kind of what we've been doing. And also we sort of, it seems like on one of them, we're just getting in there without any kind of funding or anything. But I think if we can show, like you were saying earlier, the value of our services, then I think that they're going to be able to sort of write us in or support us in funding. I know with the one with the community health centers, we do have a grant from Allegheny Ministries that is paying for someone full-time for 2 years, which is wonderful. But when I did approach them about the, I get the letters wrong, but the funding that NLADA listed and that you could apply for, where there's some rural funding for, I guess, populations that don't have as much medical services, and that did fit within our counties and within this medical legal partnership. But when we approached them, it was kind of, there wasn't enough time to do it. And I think when we build the relationship over this year, I think that if there's that funding opportunity presents in the future, I think that they would be much more likely then to say they're going to add us and apply for the funding. So I think it's just about kind of building the relationship and showing the value of the partnership. And then I think we're going to be in positions to get more funding. And I don't know if that was helpful.
Okay. So just, Amy, thank you. so much. That is right on. And I really appreciate your reflection. And I think that is one of the biggest things, is to pause and think about with your partners about how to have regular communication and not presume that we know the solution to their problems. Oftentimes we don't even ask what the problems are because we, as legal aid lawyers, right, we know because we're dealing with clients all the time, but we don't have the same lens that they do, and we don't have the same team that they do. And health centers have a significant team that are thinking about social determinants all the time. And so you want to be sure that you're not duplicating effort and that you're adding value, like Amy said. So that is absolutely right. And I will also say my cautionary tale to you is that more than I care to say, programs have said, we're just going to do good work and we're going to get them to believe in the work. And that occasionally does work, right? That strategy does work. But oftentimes, the funding goes away and the health center says, oh, geez, that was great. Sorry to see you go. But you haven't baked in your activities as part of how they do business, and you haven't said up front, it costs us money to provide these services, so let's talk about how these services align with the work and the mission that you have, because, this grant is going to end sooner than you think. And so setting the expectation that it costs money to provide those services, and what does that money buy, and making sure that they know that they are going to be the purchasers at some point, and so they should be customizing the services alongside you, and that's going to make a huge difference. And that goes back to the comment about not collecting too much data. Oftentimes we think what we're collecting is helpful when we haven't actually asked our partners if it's data that's going to be helpful and dispositive to them in terms of investment and in terms of, how they allocate our services. So thank you, Amy, for that. I would just add that oftentimes we're so eager as lawyers, and our grants demand it too, that we are really just looking to start screening and getting clients in front of us so that we can get about the business of lawyering. And this is a different kind of practice, right? And so I would think first of your peers at the healthcare institution as requiring your full focus for a good chunk of time at the beginning. You will not regret that time, even if it means you're delaying opening your doors for another 2 months. And instead you're building relationships, you're going to everybody's trainings and their team meetings, and you're learning about their screening, and you're learning about how they deal with patients and what their resources are and how they think about the work. That is some of the most important work you're going to do, because you'll be so busy on the other side once you start seeing patients that you won't have time to do that relationship building. That's pivotal. So, thanks for that, Amy.
Yep. Karen Miller was unable to connect to the audio, but Karen did go ahead and send me a message. They recently started an MLP, or not recently, they have an MLP with the People's Community Clinic and the Kind Clinic, which primarily works with the LGBTQ community, both of which are located in Austin. These both started with fellowship funding, and both of the clinics provided continued funding in future years. They also recently received a grant to start a new MLP in Houston, working with cancer patients at MD Anderson. So if anyone has questions for Karen or us about these MLPs, go on, send them on in. We have run out of questions from the audience.
Okay. Great. I can freewheel it as long as people want, but I'm also mindful of folks' time and, hoping that this is helpful. And Radhika, I don't know if you have thoughts about things that might be particularly helpful for folks, on the funding side. I'm happy to expound a little bit on the funding side if people can hang in for a little bit longer on the call and then maybe want to do early dismissal. Go ahead. Sorry.
If we had an early dismissal, no one would ever complain about that, huh?
Exactly. That's how you go out with a high, right?
The only thing I would add, just, you mentioned earlier hopes that the VA go kind of in the direction that HRSA. I think in the VA context that that legal services is akin to enabling services on the HRSA side. On the VA side, it's called preventative health services. Like, the VA considers something like transportation, preventative health services, and legal aid is just like that, just like a vehicle to access the necessary health care. And I think we're making good movement on this. I know Ellen, and maybe some people on the call know, but just to say that we do have something moving in Congress now that would hopefully enable the VA to do that, to use more than their space to support the collaboration between facilities. And that was just a quick update, but just to say we know it's an important issue, and we at NLADA and of course Ellen and her team at the National Center are really trying to move this forward for everybody.
Great. Thanks. And I do want to point to, I think, NLADA did a really terrific state-of-the-field policy fact sheet that talks about the work that is being done to secure VA financing akin to the HRSA enabling and policy change akin to the HRSA enabling services policy change. And those are documents that you can use with your funders to say, look, we're not there yet, foundation, but we're going to get there. And the only way that we're going to get there is if we have the philanthropic movement to invest and help position these programs while we wait for the policy change. So the philanthropy world is going to have to provide the funding while we pursue the policy change. And that's no different from, other trajectories that we've seen over time. So I would encourage you to use the documents that are available on our website with your funders and with your partners, with your health centers, right, to have a conversation with them. I know that the Florida Collaborative, Learning Collaborative that ran a year or two ago, and one of the activities that some of you may have participated in was meeting with a community healthcare partner and asking what their priorities were and what their challenges were, what their needs were. And that was a very different approach than I think many of you on the call, particularly because I think there's some development folks on the call, right? And so there's this kind of instinct that I understand to pitch. But instead, what we needed to do was to pause and to listen to what are some of the things that are really challenging them, and then figure out together with them where we fit. And that is going to hopefully ensure a tighter alignment, and a partnership rather than, trying to slot legal aid into, a particular activity, and instead, hopefully you will become part of the fabric of the health center and ergo part of the budget and priorities and leadership of the health center. So that's what we're seeing. And again, I appreciate the message from Karen Miller because, some of the work that's happened at Austin People's Community Clinic is really informative because they have, used, I think, effectively philanthropic dollars to pave the way for sustainable operating dollars that come from a health center. And that is part of the goal, right? If this is a service that they value, then they need to pay for it. And part of your job is to work with them to figure out what should that service look like. Okay, we have another question that just came in. I work for an LSD-funded organization, curious about any efforts to work with state human services and health departments to promote this work. What was the goal and what was the result? So I think that, we've had different programs over the past few years, and if you get our regular update from the National Center, we try to circulate resources from the healthcare world that talk about how the healthcare landscape is shifting and how health departments are much more active than they have been in healthcare reform, some of which are actually, becoming federally qualified health centers of their own accord, right? Some state health departments also operate federally qualified health centers. And so there's a real need, I think, in the legal aid world to educate ourselves about the healthcare landscape in your own community, right? Can you identify where the safety net hospital is? Who are the federally qualified health centers? What are the priorities of your local health department? And is there a place where you can add value for your local public health departments? So the answer to your question is absolutely. There are places where the LSC-funded organization has been pivotally important. So as an example, LA County, the work that they're doing and both non-LSC and LSC-funded programs united together to work with the Department of Health and Human Services for LA County and their medical legal partnership. And that work is featured in a couple of different issue briefs on our website. So I think, behooves us to really understand the landscape around us. It's complicated, and you'll need some ambassadors, and you will need some folks to help you understand, how the money flows and where the practices are, because it's complicated and it's moving fairly fast in a way that, the legal aid community is not, right? We're much more static. So I think that is a place where you can get some guidance, and I think Janice's experience is actually fairly common, where once you start talking to healthcare partners, whether they're hospitals or health centers, they will fairly readily start to try and think with you about how to weave your work into what they do, and then that's where really understanding what their goals are becomes important. So I hope that answers your question, Megan. Any other questions coming in? Do we have?
Yep, I just forwarded you one, Ellen.
Okay. So does NCMLP give quality improvement coaching calls for MLPs or any type of evaluation service one-on-one? Yeah, we do not, thank you, Maggie. We do not have capacity to do that level of coaching or work, right, with, a couple of hundred programs just in health centers around the country. So that would be something that you could talk about securing in terms of a contract with somebody like Mallory. And I would also say that in terms of evaluation services, one of the things that we've been talking about more and more, in fact, I spoke with Mallory about this recently, is I think that for legal aid, the evaluation budgets tend to be so low that it's pretty important that you keep it local and manageable. And so that's going back to Megan's prior question. That's a place where public health departments and public health schools and public health organizations can really provide a benefit. They don't necessarily need to be drilled down on MLP per se, they can provide enormous value in terms of evaluation resources, because public health evaluators, medical legal partnership is in many respects a public health intervention, right? And so I think between the Public Health Law Network folks, and give them a Google for somebody that we work closely with, as well as public health practitioners in general and public health organizations, may be in your, probably closer at hand in your community than trying to look for a national resource, right? So I would there's lots of different ways to skin that cat, depending on, where you are in the country and how close you are to academic resources, how close you are to, the Festival of Public Health organizations that might be thinking about social determinants intervention. So just some thoughts for you all. Again, those budgets tend to be fairly low, and so you want to make the most of your dollars.
Great, thank you. So don't have any more questions from the field. So I think, Ellen, do you have any last imparting words of wisdom for the attendees that are still with us, or anything that you want to make sure we cover before I wrap up?
Yeah, thank you for that. I just really appreciate everyone showing up and your openness. And I would direct you to, again, the Austin People's Community Clinic. There's a really nice, it's one of my favorite things, is they had, Kate Markle on our team did a really nice timeline where they talked about all the choices that they made and how long it took them to kind of put together the program that is active now. And, it doesn't happen overnight, and it takes work. But I think the ongoing growth of the movement is a testament to why people hang in there, because of how satisfying it is to tackle these problems in a different way. So I would just say, hang in there, take your vitamins, and, build those relationships.
Great, thank you. What a good note to end on. So before you all go, if you like this webinar and some of the other things that NLADA does and the Justice and Government Project does, we have launched a survey to try and help identify how NLADA can help better meet your needs, and where we have helped you access non-LSC federal funding. So that's the first point. And then the second point is that we recently started a monthly newsletter with all of the hottest and newest research studies, federal funding sources, and legislative updates. So we have them on veterans, opioids, reentry, and then we will have one this month on foster care. As it pertains to this webinar, we do have one in the works on health. So how can legal aid organizations or medical legal partnerships address the underlying social determinants of health, which is very relevant to this one. So if that sounds interesting for you, go ahead and sign up for our newsletter. We send it out once a month, and we promise to not spam you. So with that, thank you all for attending this, sending in your questions, and taking the pre-webinar survey. And a huge, huge thank you to Ellen from the National Center for Medical Legal Partnership. We couldn't have done this without her and her resources and wisdom. So thank you very much. I hope you all have a great rest of your Tuesday. And let us know if you have any questions that you didn't feel like we got time to answer. Thanks.
Thanks, Casey. Thanks, Radhika.
Thanks, Ellen. Bye.
Thanks.